Okay, hello friends. Today myself talking to myself because I normally clock out after a 10-minute video, and I'm really trying to condense all this into a 5-minute brain dump, and I'm gonna try to make it happen. I'll try not to talk too fast. I'll try not to talk loud. I'll really just try to just get this over with. Okay, I already have this written down, so that's what I'm gonna start with today. So I'm gonna go over shocks. Like I said, note preload is volume, afterload is resistance. Okay. Let's start off with septic shock. As we all know, things that can cause septic shock is going to be infection due to this being a systemic immune reaction to infection. Something that may pop up on the test that I have seen on UWorld questions is that patients who have recently had, let me get away from the mic, sorry if I have a little bit popping. Patients who have had organ transplants are at risk for septic shock because that new tissue is coming in and the body is having that inflammatory response thinking that an infection has entered it. So they are at risk for having this. So some cardiac manifestations you might see, tachycardia. So I don't like putting that up there, okay? I'm going to, but just know all of these, you're going to be tachycardic. Do not use tachycardia as your differentiator between these, okay? So honestly, put a little line between these, okay? All of these have tachycardia no matter what, okay? Do not use that as a differentiator. Septic shock is going to have low blood pressure, tissue hypoxia. Your temperature can be low or high. I think that's something that people often get. You hear infection, they're like, oh my God, it's going to be 100 degrees. Remember, with septic shock, they can have an infection and it can be low. Don't let that trip you up. Myocardial dysfunction and low ejection fraction can be some causes of this as far as cardiovascular goes. With the respiratory system, hyperventilation, respiratory failure, hypoxemia, and ARDS can cause septic shock. One thing I wrote is that when you're in septic shock, you can start with respiratory alkalosis and progress into respiratory acidosis, because as it progresses, everything is shutting down, right? So just know anything with respiratory acidosis is going to be a late sign, because you're going from being hyperventilating to dead, right? You're like not breathing. So just keep that in mind. Like even this says down here, your neuro, coma's late. Coma's a late sign, right? Okay. Decreased urine output. It's kind of expected with all these, right? Again, neuro, changed LOC, confusion, agitation. As far as neuro goes for the rest of these, I don't like using that as a differentiator, because all of them are going to have anxiety, confusion, and agitation, right? So again, I wouldn't make that my differentiator of these shocks, okay? I would not at all. All of them are going to have anxiety. All of them are going to have confusion. All of them are going to have agitation. What can differentiate this from the rest? They go into a coma, a late sign. Your patient's coming in, they're hypoventilating, they have a high heart rate, low blood pressure. Oh my God, their temperature is 97.0, right? They're starting to go down, 96.5. Automatically, I'm going to think septic shock, okay? As far as GI goes, key differentiator, GI bleeding, paralytic ileus. You will see that with septic shock. Skin is going to go from warm to flush to cold and clammy as a late sign. Your main diagnostic labs for this is going to be an increased lactate. Remember, lactate is a key indicator for septic shock. You're going to have positive blood cultures, and you're going to have an increased prolactin, and you're going to have decreased urine sodium. So labs to remember of differentiating things: lactate, prolactin, urine sodium. Obviously, you're going to see differentiating white blood cells. That doesn't matter, right? Okay, lactate, prolactin, urinary sodium, and obviously blood cultures. Like if you see a blood culture, boom, you know what that is. Remember, you get blood cultures first, okay? Moving on. Hypovolemic shock. One thing to think about when you think hypovolemic shock, think volume. So any type of liquid that can come out of your body can cause hypovolemic shock. You're throwing up, you're bleeding out, you're peeing too much, can cause hypovolemic shock, okay? What are some cardiac manifestations you'll see? Decreased preload, increased FCR, decreased cardiac output, decreased CVP, decreased POP, and decreased cap refill. Your key differentiators, again, I have them underlined in purple, so hopefully you can see in the video. Decreased preload, decreased CVP, decreased POP. You see those three, you're automatically thinking hypovolemic shock, right? So now moving on to respiratory, obviously they're going to go from tachypneic to bradypneic. Just remember, anytime it's going from I'm breathing fast to I'm breathing slow, slow is a late sign, okay? Just remember that. Decreased urinary output, decreased cerebral perfusion, okay? It's kind of a little bit different. As far as GI goes, absent bowel sounds. You will have absent bowel sounds because remember, you're losing all this fluid out of your body and it's trying to compensate. Why in the heck are you going to have bowel sounds if you're bleeding out, right? Your body's not caring about that right now. As far as skin goes, you're losing blood again. So, or you're losing any type of volume. You're throwing up. You're going to be pallor. You're going to be cool. You're going to be clammy. As far as diagnostic tests goes, I feel like the two that I wrote down from what we were given, that are going to differentiate it from others, your hematocrit and your hemoglobin, because you know for a fact both of those are going to be decreased, possibly to you bleeding out, you know. I don't always think, though, with hypovolemic that you just have to be bleeding out. It can also be caused by you just losing too much fluid in general. But for testing purposes, hematocrit, hemoglobin, low, low, low. Once you see that and you go, oh my God, that's really low, automatically think hypovolemic. It's a volume issue, okay? I don't know if I said this, but things that can cause, like I said, I did already say that. I'm going to skip that. But yes, moving on. Sorry, I'm trying to talk really fast. Moving on to cardiogenic shock. So remember we said when you see cardiogenic shock, you're going to think it's a pump issue. So things that can cause cardiogenic shock, obviously, is going to be pump failure. Another thing is that remember that you can have mechanical issues arise. So kind of like what we talked, I can't remember what disease it was, but it mentioned that it can have rupture of the papillary muscles. That can cause cardiogenic shock. Another thing that I noticed in some of the things that I saw is that having medication toxicities can cause cardiogenic shock. And specific medications that I saw was beta blockers and calcium channel blockers. So some cardiac manifestations that we may see, obviously tachycardic, low blood pressure, low stroke volume, low cardiac output. Differentiating things you're going to see: increased POP, increased CVP, increased CVP, increased POP. Those two things are going to be increased when you see cardiogenic shock. You will also have a narrowed pulse pressure and you will also see cyanosis. So what are some differentiating things with respiratory? Obviously, they're going to be tachypneic, like everything else. It starts out that way, right? What's different? Crackles. Crackles are going to be different. You hear crackles and you're seeing all these other manifestations, automatically think cardiogenic shock, okay? Why? Because here, like you see, your body is having sodium and water retention. You're becoming kind of like fluid overloaded, right? That's why you're going to hear the crackles. So if you see this, you're going to be like, oh my God, they're retaining this. So obviously they're going to have crackles. And if they have crackles, and they're going to have an increased CVP. And what's CVP going to cause? A narrowed pulse pressure, because all this fluid is just retaining and pushing through, okay? So now moving on to decreased cerebral perfusion. As far as GI goes, decreased bowel sounds, and I noticed on Mayor's thing it said nausea and vomiting. I don't know if that's necessarily a key differentiator, but just put that on there. Skin is going to be pallor, cool, clammy. Main diagnostic differences between everything else, I need to take this away because something else can have that. They're going to have an increased BUN, okay? Obviously, you're going to see increased BUN. You're going to think this because, like I said, they're retaining all this sodium and water. On top of that, they have decreased renal blood flow. So you're going to have decreased renal function, right? Your EKGs are going to show dysrhythmias. On your echoes, it's going to show left ventricle dysfunction. Biggest thing is when you see a chest x-ray, it's probably going to show some sort of infiltration in it. And basically what that is just fluid in the lungs. You're going to see that because of everything that's being also retained. So say you get questions like, oh my God, pulmonary infiltration, I don't know what that is. Fluid. When you see it, fluid. Automatically think fluid. And when you think fluid, you're gonna be like, oh my God, what's the one thing where they hold fluid? Cardiogenic shock. Why retention? Why crackles? Why they have a narrowed pulse pressure and increased POP and CVP? Okay, cool. That's all I got. Hopefully, I talked fast enough, but not too fast. And I hope that this wasn't 10 minutes, and it probably was, but it's okay. So that's cool.